Well, hello everyone and welcome to this session. My name is Megan Astor. I am Deputy Director of Health and Biosecurity at CSIRO. I'm not an expert in this space. I've joined that role 2 weeks ago, but I have worked in the health and medical research landscape in Melbourne for quite a few years now, and it's really lovely to see some familiar faces in the audience. So it's my pleasure to moderate this session of Lightning Talks, a regional showcase focused on new horizons in global health. I would first like to acknowledge the traditional owners of Naarm, the people of the Kulin Nations on whose country we gather for this event today. I pay my respects to the elders past and present, the elders of First Nations community attending this summit today, and any First Nations colleagues in the room. We recognise the unique, crucial and enduring contributions of all First Nations communities around the world to health and wellbeing. So thank you for coming to this session in particular. I know it is a really difficult decision choosing which session to attend when there's such a great program on offer. I applaud you if you took the stairs, even if you walked up the escalators, and I know your future cardiovascular health will also thank you. So this session was really planned to shine a spotlight on innovations relevant to the global health context. Our speakers will talk about some new challenges and opportunities for intervention and impact at the population level. We know to innovate we need a really in-depth understanding of unmet needs, and we heard this morning that that really comes from the community perspective. We can have a great idea, a great technology invention, but unlocking the value of ideas and technologies to deliver scalable transformation of health requires a really considered path to impact. A new diagnostic created in the lab with a great patent portfolio might be a great invention, but it's not useful and it's not an innovation for our health system if where it's needed most can't accommodate the unit price or perhaps can't accommodate the storage requirements for reagents. At the population level, we can take a really solid view on equity and access. So technological advances that might improve stroke imaging resolution might be wonderful for those people living in metropolitan Melbourne, but if those innovations can't be accessed by our regional, rural and Indigenous communities, is that where we should be really investing our time and effort? Innovation in the global context is challenged by diverse, complex and changing environments, changing needs and changing priorities. So we've already heard through the program to date about changing climate, impact of geopolitics, consumer expectations, trust, constraints on health system expenditure. These are differences that emerge over time, but also might be differences of a short geographical distance if you cross a border of a state or national level and enter into a very different implementation environment. Understanding of unmet needs is also not static. There is ever-changing knowledge. We are creating new information all the time. We have new data, new analytical tools, new linkages and new understanding of really complex systems. So we need to take all of this into account. So it's crucial that we continuously develop and test new approaches, respond to new information and changing needs and priorities. And we don't do this as a single person, a single researcher. We do this in groups with community voice at the centre. We do this with government and the implementation system and end users at the table. So it's not easy, it's a long game, and I think we're all in it for the long game to create some lasting health impact for our communities. So in this session we have 5 speakers who are experts from across mental health, child health, genomics, heat impact on health and air pollution, who are each generating innovative ideas and discussing emerging concepts relevant for global health. In terms of housekeeping, we want to maximise the time available for you to hear from the speakers and the work that they're doing. So I won't be reading the full list of impressive accomplishments of all the speakers. Please do look at your programs to really read in depth about the diverse backgrounds. I'm sure there might be 20 combined professorial fellowships and things like that, if not more. So, but please do take the time to look at those. We'll have 10 minutes for each presentation and 5 minutes for Q&A. We've got microphones set up in the aisles, so do please come up and ask your questions, and it would be great to have some discussion after each presentation. So first off, we have Professor Paul Lacaze, who is Head of the Public Health Genomics Program at the School of Public Health and Preventive Medicine at Monash University, our host for this summit, who will speak about population DNA screening, a new frontier in public health.
Thank you, Megan, and thank you everyone for attending this session today. I'm going to talk about something a little bit different, which is genomics, and I really think that genomics has incredible potential as a new frontier across all of the health system, and especially in public health and prevention, and that's what my research is about, trying to realise that potential and deliver the benefits of genomics in the right way. So we're at a pivotal point in history where we haven't really implemented genomics at the population scale, but it's ready and it's coming. And each country is approaching it in a slightly different way. And it's critical that things are done the right way to maximise the benefits and minimise the harms of this incredible new technology that we have at our fingertips now. So what I'm talking about and what I focus on in my research when I say population DNA screening, it's for adults for their own personal disease risk. So that's different from newborn screening, that's different from reproductive carrier screening and maternal genomic screening and other types of applications of genomics. I'm talking about testing consenting adults for their own future disease risk for chronic diseases, so familial cancer, heart disease, and other genomically driven conditions. And the point is to shift genetic testing from a diagnostic mindset after disease occurs to a preventative mindset before it happens, so we can realise that preventive potential that we know is there. Genomics can pinpoint disease risk, yet we're not using it for prevention yet. And that we think that it's critical that genomics is used to encourage proactive health behaviour and empowerment of people to take action and get access to the effective interventions to manage and reduce risk that are already available. But we're just not finding the high-risk people out there in the general population who carry high-risk DNA variants. And how do we find them, and how do we do it in a responsible way, an evidence-based way, and in a way that's aligned with our national healthcare system? And each country has this challenge ahead of them, and Australia has a lot of advantages in our population size and our strength of our public health system to do it the right way. And so we're actually taking a leadership role globally in the way I think that it should be done. And that's to maximise benefits, minimise harm, ensure and prioritise equity of access, and adhere to the foundational principles of population screening, and critically to maintain public trust. We know there's a lot of scepticism and concerns out there when you talk about genetics, genetic privacy, data privacy, the custodianship of people's DNA material. These are all very serious challenges and issues that we need to think about seriously and get them right if we want to maximise participation and public trust. We have a framework for population screening in Australia that has guided previous population screening programs that have been introduced and are effective, and the framework already foreshadows the use of genomics in population screening. So what we're trying to do is build a genomic screening program in Australia that adheres with the long-held principles of population screening that have been around for decades. And currently, very few people have access to genomic testing for the conditions that I'm going to talk about, and the people that do qualify typically have already had a cancer or a heart disease event and a very strong family history. So that the criteria is too narrow. We're not finding the majority of people out there who are at high risk. And this comes at a time when there's huge growing interest and demand in the general public for access to preventative genetic testing. So our program is focused on these three conditions, and we've taken a very narrow view of the genome to only test for genes that are highly medically actionable. So this means that there are effective risk management interventions already available, supported by clinical guidelines, and we've only chosen the most high-risk or penetrant genes for these conditions. So the first condition is breast and ovarian cancer, driven by the BRCA genes, which you've probably heard of. Angelina Jolie was affected and is a carrier. About 1 in 250 people carry a variant in these genes. Lynch syndrome, another familial cancer syndrome that predisposes to bowel and other types of cancer, and genetic high cholesterol or familial hypercholesterolemia, which can be managed with lipid-lowering therapies. And combined, about 1 in 75 people carry a genetic variant that puts them at very high risk of these conditions. It doesn't guarantee that you're going to go on to have cancer. It should be considered a risk factor. And critically, there's something you can do about it if you know in time. And these conditions are caused by single gene changes in single genes, which make them monogenic conditions. And so we, a few years ago, took the first step to take this on and bring genetics into the general population. And that was the DNA screen program, which we designed to assess the public acceptability, scalability, and cost effectiveness of this new approach. And to again, build something from first principles in the right way, in alignment with screening principles, to introduce genomics into population screening for these conditions specifically. We set out to screen 10,000 adults aged 18 to 40, so in that preventative window before most cancers and heart disease events occur. And this study was designed specifically to align with the Australian public healthcare system. But critically, it's a proactive, purpose-built program, not a retrospective screening of an existing biobank and then recontacting people years later with their genetic result, which is highly problematic and not the way to deliver actionable genomic information to people. Everyone who participates in this knows what they've signed up for and knows that getting that information back is the primary reason for participating, not a secondary or additional finding. We've assembled a very broad national network of scientists, public health experts, clinicians, clinical sites and consumer groups to design and deliver this study. So I would like to acknowledge that I'm here on behalf of all of them. And I don't have time to go through all this, but in a nutshell, people can sign up for this program off their own bat online. The whole thing is digital. That includes a first registration step, then informed consent with videos and materials that we co-designed with the consumer reference group. And then if once they've enrolled, they will be posted a saliva DNA collection kit, which is then returned to our lab at Monash, which is a genomic screening facility where we have an assay purpose-built to screen for these genes. And for the 98% of people who a high-risk variant is not detected, they get an electronic results report. And for 2% of people for a high-risk variant, they get recontact and genetic counselling and a referral into their state-based familial cancer centre or genetic health service for subsequent confirmation testing, risk management advice, and clinical care into the future. And our study is tracking those people longitudinally. And in parallel, we are doing a health economic analysis. So you can go to the website and look at all the materials that we co-designed, and that's all online, including videos. So we launched the study in August 2022 and had lots of media interest, and 10,000 people signed up in the first day. So we essentially reached our recruitment target in 24 hours, and we now have over 28,000 people who have signed up, even though the study's actually closed. And fast forward to now, we've finished sequencing and return of results for over 10,000 participants, which is what we set out to do, and we've identified around 200 people from that group with these high-risk variants, so about 2% of participants. And we're getting results back to people in 12 to 13 weeks after we receive their sample, which is critical because it's close after the point at which they provided informed consent and a sample, so the information is timely and not coming out of the blue. We have great representation across the country. Here, this is the slide I wanted to show. So this shows our enrolled cohort of about 10,000 participants, and we were extremely happy with the representation we had across age, across state population size. So the purple is the ABS average and the green is our cohort. And we exceeded our targets for cultural and linguistic diversity, and we almost achieved a 3% First Nations participation rate. And this is just with our generic kind of recruitment that happened in August 2022. And we have pretty good sign-up as well from remote regions and across socioeconomic deciles. So very good representative pilot study cohort. And these are the results. So these are the variants that we found by gene, and the most common genes were hereditary breast and ovarian cancer. Each one of these represents an individual whose life might be changed by this information, and who may be able to now prevent cancer from occurring, and their life could be saved. And each one of their first-degree relatives has a 50-50 chance of having inherited the same high-risk variant. So this is now leading to cascade testing into those families to find more of those high-risk family members. And we have a genetic counselling team who are recontacting and providing support and information to people, supported by these consumer groups throughout the country. So providing that adequate support is very important. And critically, when we retrospectively assess the family history and personal disease history of these people, very few of them are meeting the current clinical testing criteria for genetic testing in Australia. So we know that they're at high risk, we know that they're out there, but the current status quo is just not finding them. So we think this is the way to do it into the future. However, there are challenges. So we know that once we refer these people into services, there are sometimes long appointment wait times and bottlenecks in the clinical system, and those need to be addressed and streamlined into the future in order to provide risk management in a scalable way. We're doing psychosocial studies to prove that this is safe and acceptable to people, and those are ongoing. And we have a cost-effectiveness analysis health economic study now published and open access to view if you're interested. And we have calculated that the intervention and this type of screening would be highly cost-effective in the Australian public healthcare system at a certain cost that we think is definitely doable per participant. Of course, there are many challenges with scaling up feasibility, public education awareness, medical workforce training, capacity building, and these, again, are going to be challenges that every nation will have to address and ultimately solve in order to realise the potential of population genomics. So with that, I'll end and want to, again, acknowledge and thank all the people and the participants who have been involved in this program and for your attention today. Thank you. Happy to take questions if there are any.
Can I ask, what are the next genetic conditions that are on the horizon? Are there other things that you're looking at? What would be the next exciting thing to look into?
Yeah, so there's a debate, I suppose, about which additional genes or conditions we should screen for, if any, and there's no consensus globally about what should or shouldn't be screened for in this setting. And each country is taking a slightly different approach. So we've taken a minimalist approach, but we are looking at the next set of conditions, which might be more moderate risk genes for breast cancer, for example, hereditary hemochromatosis, and some other cancer genes, cancer predisposition genes. But we're approaching that with a lot of caution. So we think that there needs to be a framework for the assessment of additional genes and conditions before they're added. And we shouldn't necessarily be adding things. We should actually be prioritising finding more people with these conditions that we haven't found yet as the first priority.
Hi, great presentation, really fascinating. I'm really curious about how genomic testing compares with other screening approaches for issues like overdiagnosis and that kind of thing. I'm sure you've given lots of thought to, but yeah.
Yeah, so all population screening has to consider overdiagnosis. But I guess I'm not too concerned because with these conditions, underdiagnosis is such a glaring issue and there's clinical consensus that everyone who carries a pathogenic variant in these genes is at high risk and ought to be in risk management. So the real problem is underdiagnosis rather than overdiagnosis, in my opinion. Yes, thank you for bringing up that important point. So that is a barrier that currently exists because it's still legal for life insurance companies to ask for and use genetic results in underwriting, which we're trying to get a law to ban that. And we're quite close in Australia, and many other countries have done that. But even despite that being an issue, we still had overwhelming interest and acceptability for people to sign up. So it has to be weighed against, potentially your life being saved by the information. So that's a barrier, but that we would like to be removed, no doubt. And there are other issues like skepticism about data privacy, what's going to happen to my sample. We designed our program in a way that people could tick a box to say, please destroy my sample and data after the screening has been undertaken. So they could still participate without any kind of worries about a black box. Those are only a couple of the issues or barriers. But, I really think that there's a huge demand out there for this type of testing. So that the issue isn't the barriers for people to participate. It's actually how we're going to service that demand and deliver access to this life-saving information to people in a timely manner. It's going to take us decades to catch up with that demand.
Ben Canny from Adelaide. Do you have any sense of the economics of the exercise in terms of the cost savings as a result of the diagnosis?
Yes.
Versus the cost of the testing? Yeah,
we just published that late last year, and all of those calculations have been made for the conditions. The model was the exact same conditions that we're screening for in the pilot study, and so it was well below the cost effectiveness threshold in Australia for a screening program.
Thanks for that great presentation. You said that the first step when people are notified is to confirm the genetic screening results. Do you have any data on whether there have been any false positives in your screening?
No, it's 100% confirmation rate. And actually the discussion is now moved towards we should be removing that step because it's duplication and it causes a delay in people getting to their eventual risk management and care, and that we should actually either take that validation step on as part of the program or bypass it altogether. So the actual screening test is highly accurate and has very few false positives. Basically zero.
Thank you, Paul. We will keep it moving in the spirit of lightning talks. So next I would like to welcome to the stage Professor Chan-Chuan Chang, who is Distinguished Professor of the Global Health Program in the College of Public Health in the National Taiwan University.
Thank you, Megan, and I'm proud to be here to represent National Taiwan University and MA Alliance to co-sponsor this important meetings and sessions. And as you can see from this slide, this is the earthquake we just got at the beginning of the month and yesterday, another tremors. And so we are from a place of high natural disasters. So the perception of risk is very different from people who are not in this area. And our Asian Pacific actually is very prone to many disasters, natural and man-made. So I think that's the whole reason I'm trying to talk about this today is during the pandemic and after the pandemic, what should we be changing the way of innovations, especially for populational health. Next. So I would focus first on islands or island-like nations. Okay. So if you look at these tables, if you count for areas, and we only have 2 big island countries in this area, like Australia and Indonesia. But if you count the population, right, Japan, Korea, and Philippines will be big countries. So when we talk about big countries, it's different from like if you count India and China, it's very different. So island Pacific and Asia and continental Asia is a little bit different, and the approach of dealing with disasters or pandemic could be different. And if you look at the economy and health expenditures in economy and healthcare manpowers, and there's statistics people usually use like percentage of health expenditures, and there's only like 3 countries about 10%, and another 3 around 7%. yeah, from different economy among these islands. And you can see the life expectancies are quite different. So our region is very diverse. And in terms of manpowers, usually we use the per thousand populations and how many doctors, nurses we have, right? And you can tell from this that Australia, that's Korea, and New Zealand, and Singapore, just for nurses, they are quite good, right? About 10. But if you look at the square kilometers, it's very different. So Singapore is very high. So let's give us an implication. The health system in Singapore is good, but can it be applied to others island nations? And there's a lot of things we have to modify in terms of accessibility and affordability. So that gives you a sense that our region, if we are doing very well, and there should be some wisdoms we can contribute to global health. So I plot the cases and deaths weekly along these COVID-19s, and this is a failure for our humanity, right? So many deaths, so many cases. So my bottom line is there's no countries and no academic institution can claim we are successful. We all fail to some extent. And that's a foundation for us to improve better for future preparedness. But if we look at it regionally, we can divide it into two periods. So the first periods, Europe, North America, suffer a lot when we didn't know what virus and what characteristics of the virus are. But our region performed very good by applying non-pharmaceutical interventions, which are mainly behavior or regulation-related interventions. So this is something, if we have a pandemic occurred, they have to ask countries in this region why we can do that. I think one reason definitely is islands. It's easier to implement a lot of border control, but there's more than that. I think culturally and trust at the beginning, I think that would be important. But in the later part of this, especially during the Omicron, when therapeutics and vaccines are available to the world, but not really available to these regions. And we all suffer very bad. If you can come to the last part of this high peak, there are these regions. And until now, in Taiwan, we still register around 30 deaths per week related to COVID, and 90% of them are not boosters, and majority of them are age about 65. So this is still a pandemic going on, and currently no other infectious disease kill people more than COVID in Taiwan. So, we have to be careful for this. But if you look at the left-hand side, the atmospheric carbon dioxide from 1955 to 2024, and it's increasing, So 1958 is the day before, the years before I was born, right? So I was born as a relative low carbon society. Now we are living in high carbon society. So in terms of climate crisis, I'm doing environmental health research for 3 decades, and I claim I failed, right? Through publication, I still cannot change the policy to stop the Earth keep going, and this warming keep going during pandemic, right? Almost 3 ppm increase during pandemic. So for years, the virus kind of stopped a little bit emissions, but very soon they come back. So I'm thinking about during this COVID, there's a need for more PPP, but I switch public and private as private-public partnerships could be one of the solutions for the futures, because we need all sectors and disciplines to be involved, and we need the society to be changed. And how to do that? I think we have to have more innovation, and this innovation should be more open, input from private, and should not only rely on government set policy to move the innovation. I think this kind of things, the thing I was doing during the pandemic, I stepped out from academic, try to help establish international think tank, try to think about this. So I think we have to have innovative policy for resilient planet, and that should be sustainability, health, economy, and innovation. So that's why we set up a Center for Asian Pacific Resilience Innovation we call CAPRI. It's a new think tank focusing on the intersection of health, environment, and economy. Our chairwoman is Professor Shirley Lin, and this CAPRI's research will enhance global resilience and promote innovative governments in the Pacific and beyond. And we have international advisable, and it's from Australia, okay, Malcolm Turnbull, and he gave this talk in Taipei, said that in the Asian Pacific, CAPRI is making a real difference in health, environmental, and political resilience, so that we can witness shocks. So we started building this and try to bring more people from really go beyond this traditional cooperation. So some of the fellows like Mina Khan from Korea, and she talked about a resilient health system can promote confidence and trust in governments, institutions, and health systems, right? When an individual has trust in their government, they will be more likely to seek necessary health care service, follow public health guidelines, and cooperate with containment measures. So I think trust is very important, and unfortunately, in the past months, Korea has doctor strikes, and there's single-payer health systems has some drawback, and trust apparently did not exist between physicians and government. So a lot of work to do. So we have Malcolm as a chair, and Jose Barroso Gavis as our members, and we have people from US, France, and India, Taiwan, Malaysia, and Singapore, and Hong Kong, etc. So I try to build more, expand, to have a platform for cooperation. I think this, and also it's not just public health field. We have to stretch out and to former politicians and former current executive of industries. And also have global networks. One thing I learned in Taiwan is public health become a mainstream wording among all the people, including the tech companies like TSMC, the most important company to supply this semiconductor chips, right? And also epidemiology is a word they understand. Then they understand public health, global health. So that's we are trying to convince them they can do more for public health. So I think we have to, as a global health practitioners, try to reach out our hands to bring more people in, okay? So one of the projects we are doing is a partnership for health system sustainability and resilience under this LSE, World Economic Forum, AstraZeneca, and WHO Foundation, Philip KPMG. So if you look at these combinations, you try to say, oh, this is a kind of soup we have to cook in the future. Try to bring people at the beginning, and we're trying to, and they have produced several reports in Europe, but they asked CAPRI to do for our regions. Their original methodologies on resilience and sustainability, right? A health system's ability to prepare, absorb, adapt, to learn, transform, and recover from the crisis, one of short-term shock and accumulated stress. That's resilience. That sustainability is a health system's ability to maintain improved population by continuing delivering key health systems functions and adapt to changing contents. So these are the topics like population health, environmental sustainability, workforce, medicine and technology, service delivery, finance and governments are 7 important things that contained in this research. But we bring it to our region, say we have to emphasize environmental impact on health and health system in our region. We have to highlight important community levels, right? That's a theme of this conference. Also, we have to consider the role of traditional medicines practice in different cultures. So there's, and we identify through our region, there's aging population, climate change, digital technology, and workforce shortage are 4 main topics for resilience and sustainability of health systems in our region. So we work on this, and we are working on this, and we will work more on this. So I talk about island, but if you include China and India, the population, the land, etc., and carbon dioxide emissions, we are more than half. Okay, so if we can bring these islands, nations' wisdoms of dealing with pandemic, and 2 big continental countries, ways of dealing with sustainability and resilience, probably we can provide the true solution for global health, which would be, I think, would be much different from the perspective from Europe or from North America. That's what I hope for to convey clearly in these sections in Melbourne. I think we have to think big and work together. So with this, I conclude my talk. I hope I convey clearly. We need technology. We need a lot of research, but we need an innovative policy platform that we can move forward. Thank you very much.
Perhaps I could ask a question, just in your background in terms of air quality and pollution, etc. How much is that a key factor in the discussions as well that we need?
Yeah.
This interaction between carbon societies and.
Sure, you know, this air pollution and carbon dioxide, we have the butterfly effects, right? It gets warming more by fossil fuel use, the air quality will be bad. And we do have a lot of colleagues in these regions working on air pollution research. And I think I was one of the pioneers in Asia to talk about the PM 2.5 back almost 25 years ago. And yeah, that's closely linked. And how to transform is the big issues, right? And it's a headache for many countries. And if we don't use fossil fuel, what we have. And a lot of this island nation has no natural resource. So how to have the energy, which green and healthy, is very big challenge for us. And so in future research, we need this kind of interventions thought before we can implement any health studies. I think that will be more beneficial. Otherwise, public health in the past always, convey very doomed futures and without solutions. I think that's not sufficient. Yeah.
Oh, it's working? Yeah, thank you very much, Fiona Russell. My question is really related to, in terms of the preparation of health systems, also the consideration of children and young people and adolescents and the critical role that education and schools play in that in particular, and also all the primary health care and all the preventative activities, which, as we know, those indirect effects have been probably the worst for the younger generation and may be impacted for a lifetime. So How in the planning, I was just sort of wondering how you're integrating some of that as well as the disease control and obviously responding directly to the disease itself, but then in terms of the preventative side and the future generations as well and the impact on them. Thanks.
Yeah, that's a good question. So you think my pictures, if you hop from Korea to Australia, so a majority of these big countries like Taiwan or Japan, we all have universal health care, right? But in the past, the health systems focus more on treatment, and many of them the preventions are not covered, but the government public health measures jump in to do from the maternal child health to the diabetes, obesity, and kind of a control. But in the future, this should be merged, and how can we design a sustainable reimbursed system to encourage these kind of things rather than high cost cancer treatment, etc. So this is a kind of thing we can learn from each other. Different countries have different schemes, like fee-based, and some are tax-based. All these kind of things that we have to learn, and I think we can share. And on this trip, I talked to many citizens I know from Taiwan living here, so doctors, and I know the difference in person, how the systems work. I think this kind of sharing is very important. So I agree with the preventions, actually very important for all the diseases we are dealing with. Hey, thank you.
And next up we have Professor Ollie Jay, who is Director of Heat and Health Research Incubator and Thermal Ergonomics Laboratory at the University of Sydney. We'll speak about how simulating heat waves is helping us prepare for a hotter future. Thanks, Ollie.
Thank you, Megan, for the introduction. Hello, everybody. Great to see such a full room. So I'll start off with probably stating what will be completely obvious to hopefully every single person in this room, is that our climate is rapidly changing. Now, there was an article in the Australian newspaper about our research that was published yesterday, and judging by the number of abusive emails I received yesterday afternoon, not everybody agrees with this statement yet, but nevertheless, we still have work to do. It's not the increase in average temperatures that are the problem from the perspective of heat stress on human health. It's these bouts of extreme heat, often coupled by extreme bouts of humidity. These have an enormous impact on human physiology, and they exert an enormous amount of strain on the human body that result in an increased risk of heat-related morbidity, but also heat-related mortality. And there's lots of examples of very impactful heat waves around the world that we see every single year. Now, I'm a physiologist, a thermal physiologist, and what we do is that we try to understand what happens inside the human body when we're exposed to extreme environments. And we really focus on what the underlying pathophysiological mechanisms are when people are exposed to extreme heat and what leads to those negative health events. And over the past couple of decades, myself and a lot of my colleagues around the world in the same field have identified that there are three primary pathophysiological pathways of heat-related mortality and morbidity. And it often surprises people that it's not just a matter of people overheating per se. There is classic heat stroke, which occurs when internal body temperatures reach 40 to 41 degrees Celsius. This is coupled with a low delivery of oxygen to the endothelial tissue of the gut. This results in an increasing gut permeability. Endotoxins leak out of the gut, enter the circulation, and then set off a cascade of effects that result in multi-organ failure and death. It's pretty grim, isn't it? As my old PhD supervisor used to say, you can't uncook an egg. And it's very much the case with the human body. Except there's some very clever people at Flinders University who actually figured out how to uncook an egg, which is a bit problematic for this, but nevertheless, I think it still holds for the most part. But what's surprising to most people is that actually heat stroke deaths are the minority of cases that we see in the epidemiological literature. What we see is a massive signal associated with cardiovascular disease. And the heat-related cardiovascular collapse is something that is of very high risk during extreme heat events, particularly for people with underlying cardiovascular infirmities. The underlying cause of this is very different. The way in which we defend body temperature in addition to sweating is that we redirect blood away from the body core towards the skin surface to help heat loss to the environment. But in order to maintain central blood pressure, we need to increase something called cardiac output. That's the amount of blood that's pumped around the body every minute. And the only way in which we can do this when there's so much blood sitting in the skin is by increasing the amount that our heart contracts every minute. So we have to increase heart rate. I often show a slide that has a heart rate trace of an 84-year-old adult who's exposed to an extreme heat exposure. And it looks like he's running on a treadmill. And he's simply just sitting there, and it's the extra work that his cardiovascular system has to do because of the heat stress that's imposed. So that's another way in which heat can impact human health. The other way is through damaging the kidneys. So people with underlying kidney disease are at a much greater risk of renal collapse secondary to dehydration. Dehydration is really important to keep in mind because that aggravates the risk of these other two things as well. So this information can equip us with biomarkers that we can use in studies to identify which individuals are most at risk and why. And most importantly, and what I'm going to talk about today, is what we can do to try to reduce that risk when the most vulnerable people are exposed to extreme heat events. And just one thing I want to quickly clarify is that when we're thinking about the most vulnerable during extreme heat events, it's not just biological vulnerability, it's also a reduced behavioral adaptive capacity to extreme heat. So these are people that are living in low resource environments that don't have access to air conditioning, and therefore by necessity we need to find solutions that are very simple and straightforward and plausible in a low resource environment. So the way in which we do this at the University of Sydney is that I'm director of the Thermal Ergonomics Laboratory, which is now housed in the beautiful new Susan Wakel Health Building on the top floor. And in our laboratory, we have a state-of-the-art climate chamber where we have the ability to simulate any heat wave of the past. So we go into the weather records, we extract what the peak temperature was, what the associated humidity was, and then we expose human participants to these conditions under careful clinical supervision, of course. And we measure how hot they become, so what their core temperature is, how much work their heart has to do, and how dehydrated they become. This also gives us an opportunity to systematically assess the efficacy of different low-resource cooling strategies. Answering simple questions like, should people be using fans during heat waves? The answer might surprise you. How much water should people be drinking? Are there other things that you can do with water in order to mitigate the physiological strain, which ultimately leads to an increased risk of heat-related mortality and morbidity? So we've been working on this for the last 10 years. We published our first paper in this area in 2015. And then in 2021, I had the privilege of co-chairing the first ever Lancet series on heat and health alongside the chair of the Monash Sustainable Development Institute here at Monash University, where we described the latest evidence driven by physiological research, which tells us what are the optimal low-resource cooling strategies that the most vulnerables can adopt during extreme heat events. I'll give you just some quick highlights. So electric fan use, for example, we know they work at relatively cool conditions, but above 40 degrees Celsius, it actually aggravates body heating rather than cools people. We also know that electric fan use, it accelerates the rate of dehydration by up to 60%. We also know that applying water to the skin surface, which is not in most traditional heat wave guidelines, is one of the best strategies for reducing cardiovascular strain when we're exposed to extreme heat. We also know that the amount of water that you need to drink to maintain hydration and ward off dehydration increases by about 6% for every degree Celsius increase in ambient temperature. So the next part of this work is really trying to translate that science into changes in policy and changes in action. Our previous speaker talked about the necessity of this. So we're partnering with public health organisations in New South Wales and here in the state of Victoria to try to translate this work into their updated guidance, and we've been quite successful with that over the last year. But that's not enough. We need to find ways in which we can reach most people in the most novel of ways. And so to this end, we partnered with Google last year through the Global Heat and Health Information Network, which is co-convened by the World Health Organization and the World Meteorological Association. We partnered with Google because they were developing a new heat alert app, which is heat alert function, which is based on every Google search app or Chrome app and every Google Maps app worldwide and every phone that has it on their device. With this new heat alert system, it pushes a warning, but we now have our research informing the evidence-based advice. So this gives us an opportunity to place the findings from our research literally in the hands of potentially hundreds of millions of people worldwide, which is a really exciting development. The next step is understanding how that change in recommendations and messaging actually changes behavior, and that's the really next frontier for our research. So I'll finish off by just describing something else that we're doing where we're leveraging this technology to try to understand what is going to happen with the future based on the decisions that we make right now. In this climate chamber, we don't just have the capacity to simulate heat waves of the past, we also partner with climate scientists to try to understand what the heat waves of the future are going to look like based on different carbon emission pathways that we set upon based on the decisions that we make from a policy and behavior perspective right now. So what we can do is demonstrate how much extra risk an elderly person is going to be exposed to in 2070 if we stay on the same business as usual carbon emission pathways. We can demonstrate what the impact will be of a construction worker trying to carry out a task that we take for granted right now, but what it might look on a hot day in 2090 if we follow certain pathways. And we think this is a really nice opportunity to generate extra information to persuade people that this climate crisis is real, it is here, but we can do something about it right now through the decisions that we make. So if anybody's interested in this work, we partnered with the BBC late last year to produce a short film for their Climate and Us series. The QR code is right there. It will take you directly to the link of the short film. It's about 5.5 minutes, and I'd be happy to answer any questions. It's 2 seconds, that's great, wow. Thank you very much.
Thanks. Great presentation. My name's Michael Baker from New Zealand. Just a question about the relative importance of humidity versus temperature.
Yep.
And sometimes we have people talk about wet bulb temperature and so on, and I think it gets a bit confusing for a lot of us.
Yes.
Can you explain whether we should be putting more emphasis on humidity?
Okay, so humidity is very important if you're able to sweat. So the reason that humidity matters is because it prevents the sweat from evaporating. Now, if you can't sweat, humidity doesn't matter so much. So what we see in the epidemiology, so you've got one of the leading epidemiologists sitting right behind you who'll be able to answer this question from a biostatistician perspective. But what we know physiologically is that humidity is very important for people who can sweat. Now, in terms of messaging and trying to get people to understand the impact of the climate, it's very challenging. So we saw that through this past summer here in Australia, where we had the Sydney Morning Herald and the Age talking about dew point temperatures all of a sudden. And that's just because that's a number that's issued by the Bureau of Meteorology, which gives us some kind of information around temperature and humidity. But it doesn't really resonate with people, and people find it difficult to answer. So wet bulb temperature alone is okay, because that's a normalized value for humidity. But that's quite good for humid conditions, but it doesn't express the risk for elderly people when they're exposed to very hot, dry heat wave conditions. Now, so we've developed a new system to try to help circumvent this problem. We've developed something called the Heat Watch app, which was funded by the New South Wales government, where we enable people to enter their own individual information, what age group they're in, what type of medication they're on, whether they have chronic diseases, and it draws from the weather information that is freely available, and then it gives them a heat stress risk score on a very simple to understand scale. And what's driving that actually is a physiological model where all of this information, temperature, humidity, wind, solar radiation, and integrating the other personal information that they've given us to develop an individualized risk score. But the important part of that is when you express it, you can't express it using some complicated scale. It's just on a simple risk scale, low, medium, high, et cetera, et cetera. And that was developed through co-design with our community partners.
Okay. Hi, Jay. My name is Tasik. I'm
Hello.
a PhD student at Monash University. I'm a medical doctor as well. Bangladesh right now is passing through the terrible heat wave. Maybe you heard in newspapers and other stuff. And I've seen a heartbreaking picture yesterday of a rickshaw puller who was killed by heat wave, heat stroke, and And the interesting part is our government is not willing to acknowledge that they have a role to play. They're throwing the burden to the people, saying you need to carry water bottles, you need to carry hand fan, you need to wear comfortable clothes. And for a rickshaw puller, the death I've seen yesterday, it's not a case for him. It's not a solution for a person who is pulling a rickshaw in my country. So if I ask you to give 3 top priorities for a government like ours, like what they can do where they're not willing to acknowledge their role.
Well, thank you for that. Well, I would encourage any answer to be aligning with the evidence that's available. We actually carry out work in Bangladesh in the ready-made garment factory industry, where we've found that where heat stress risk is actually quite substantial for people who are not necessarily biologically vulnerable to the heat, but because of the exposure and the working conditions. And so what we've done is tested the efficacy of different scalable, low-resource cooling strategies. One of the things that people always want to resort to is they want to talk about air conditioning. But the reality is that air conditioning is not a scalable solution for a lot of people in many parts of the world. It also economically won't make sense for those types of industries. So we're assessing the efficacy of different strategies that are relatively cheap, but that work. So the way in which we looked at it, we looked at ways in which you can modify the factory roof. So you can place a installative reflective roof, and that will reduce peak indoor temperatures by about 2.5 degrees Celsius, which has a bit of an effect, but not a massive effect on the physiological heat strain that I'm describing. You can then augment that effect by moving the air a bit more, so having extra ventilation. But one of the things that we find is that the efficacy of these types of strategies are really dependent on maintaining hydration, but it's adequately maintaining hydration. The trouble is that thirst is not a good indicator of your hydration status. You're typically lost around about 0.5 to 1% of your total body mass through sweat loss before you start feeling thirsty. So you're already behind the curve when you start feeling thirsty. So having hydration guidelines would be very helpful as well for coping with that. But I think what we need to do is really kind of understand that the types of strategies that we should be advocating are ones that people can use and ones that are appropriate for the setting in which they're being applied. Skin wetting is also a very good one, but less so in a humid environment because it has trouble evaporating.
Yes, so...
Question. But in fairness to the other speakers, we might keep them moving, and I would encourage people to hassle Ollie up.
Sure. Okay. Thank you.
Sorry. We have some great talks, and I just want to make sure that we keep on time and we are fair with all of our speakers. So it's my pleasure to introduce Associate Professor Hamish Graham for the next presentation, who is co-chair of the Lancet Global Health Commission on Medical Oxygen, team lead of Global Oxygen Access at the Murdoch Children's Research Institute, and associate professor of international child health at the University of Melbourne. His talk is entitled "Every Breath Counts: Putting Oxygen Access on the Global Agenda."
Thanks, Megan, and it's wonderful to see all these diverse talks today. Today we're talking about innovation. I'm going to tell you about one of the oldest medical interventions, but hopefully some new and exciting policy, technological and medical innovations that are bringing this very old medicine to the millions of people who don't have access to this every day. But first I want to introduce you to a child. This is a young girl who presented to a small clinic in Papua New Guinea. She had pneumonia, she was breathing fast. You can see in the left panel, she's really sucking in. And flashing on that screen in the purple, if you have very good eyes, is her blood oxygen level. And it's flashing at 51%. Normal blood oxygen is in the high 90s. 51% is very, very low, putting her at extremely high risk of death. You can see she's barely conscious, and that's what happens when your blood oxygen gets low. You're not getting oxygen to your vital organs, including your brain. You become increasingly comatose and ultimately die. In the middle panel is this same child just a couple of minutes later. She's still very sick. She's still got pneumonia. She still needs inpatient care. But you can see her blood oxygen level now is 98%. It's within normal range. And the panel on the right shows you the only thing that's changed in that time. So she's been put on a small amount of oxygen from a simple bedside oxygen concentrator, just half a litre per minute. And that's been enough to get her oxygen in a much safer range, and was a big reason why that girl survived. Now, when I look at this, it tells me a few things. It tells me the amazing impact that a little bit of oxygen can have. And it tells me that this is a therapy that every child, every patient should have, regardless of where they're born. But it also fills me with a bit of fear, because I know that's not the reality for most people around the world. Now, oxygen was discovered back in the 18th century. We've been using it clinically since the late 19th century, and yet the majority of patients, children like this, who need oxygen each day, will not get access to it. And I think this is a huge, great global health failing. Now, those of us in the room, many of us will have had oxygen therapy at some time in our life. If you haven't, you're almost guaranteed to need it at some time in your life. It's really the most common medical therapy, I think, that we give. Most of us in the room, if we need oxygen this week, we'll get it, and you wouldn't really worry about it. We have very good hospitals, very good access here in Melbourne. And even from those of you from other countries in the region, if you're from an urban city, if you're moderately wealthy and educated, you'll probably get reasonable access. But I want to put us in the life of an average person in low middle income countries in our region. Now, if you were to be an average person and need oxygen, about 10% of you would not even make it to a facility where you'd have any chance of getting oxygen. And there's lots of reasons for this. We heard a bit about island nations, remote communities. This child that I just showed you, she's from a very remote village in the highlands of Papua New Guinea. There's also cost. Getting to a facility is expensive for many families, particularly if it's taking away from your livelihood, away from your family. For those of you who are lucky enough to make it for a facility, another 25% of you will get to a facility that's just not adequately set up to give you oxygen. Maybe it's a really small facility and you're unable to be referred to a larger hospital. Maybe it's because, they don't have oxygen equipment, or they've got oxygen equipment and it's broken, as I've seen in so many hospitals around the world. Maybe they've got oxygen equipment, but the power's out at the moment, so sorry, it's not working. Or maybe they haven't had their oxygen cylinders supplied this week because the road's flooded or the car's broken down en route. For those of you who get to a facility that has oxygen, about a third of you won't get it even when it is available. And the most common reason that is because no one's realised that you need oxygen. Without a pulse oximeter that you saw that little girl on, it's really hard to know clinically whether you need oxygen or not. And if my hospital's already got pretty limited supplies, then we're going to be just giving it to those who are really obviously needing it. There's also other barriers. In many places, oxygen therapy costs patients more than the entirety of their entire hospital stay, more than the medication, more of the bed stay, more than everything. And sometimes it's just simply nurses are too busy, medical staff are too busy. You saw some of the nurse and doctor to population ratios from our region. Australia has 20-30 times the number of nurses and doctors per capita than many of the poorer nations in our region. And if you are lucky enough to get to a facility that has oxygen, get oxygen supplied, there's a 50-50 chance that something will go wrong along the way. They won't have the right equipment for you, who's a little baby. Your oxygen will be interrupted because of power outages or simply just running out. And this inequity is much greater in rural and remote facilities than it is in urban facilities, and much greater in poorer areas. But as you'd know, most of our policymakers come from wealthier backgrounds, urban areas, and have never seen this reality that millions of healthcare workers and tens of millions of patients face every year. Now, the good news is we know a lot about what works, and there's some really great innovations particularly come to the front over the last few years. Now, I'm representing the Lancet Global Health Commission on Medical Oxygen Security, which is a group of academics, civil society folk from across the world who've been tackling this over the last 2 years and will be putting out a report early next year, really mapping a lot of this out. But I wanted to share just a few snippets of what some of the common messages that are coming out. The first is that we need to keep people at the centre. In the past, most of our measurements have simply measured is there some equipment at a facility, and very rarely whether that equipment is being used or benefiting patients. Over the last few years, there's been some very strong advocacy efforts, and you would have heard during COVID terrifying stories of oxygen shortages and patients dying because of lack of oxygen. And a few particular advocacy movements, including the Every Breath Counts Coalition, have really managed to bring that to the fore. The second big thing is we need to look beyond equipment provision. Early in the COVID pandemic, oxygen was not on the radar of the global health community at all, and it took about a year before the big apparatuses started to put oxygen in, and it was such a failure that they ended up creating a new entity called the ACT-A Oxygen Emergency Task Force. They were really successful in raising almost $1 billion to support oxygen globally, but almost all that money went on delivery of equipment, so oxygen concentrators, pulse oximeters, but also ventilators, big PSA plants. A lot of that took months, even years, to get deployed, and I got photos from a warehouse in one of our country regionally just last week showing hundreds of boxes of concentrators, ventilators and equipment that still hasn't been deployed. So everyone sort of automatically thinks about supply, about getting equipment out, but probably the bigger gap is how it's actually used at facilities and how we actually detect and provide care to the patients who need it. The third big area is around having a systems approach, and we've heard a lot about this importance of systems thinking today. Oxygen is not something that is just within a particular sector. It's cross-cutting across many different areas, but that means it's fallen through the cracks. So part of the goal of the Commission is to really put it on everyone's agenda. So whether it's UHC, whether it's malaria, whether it's pandemic prevention, everyone's thinking, how does oxygen fit within this? And in doing this, there's some really good progress from individual countries in creating roadmaps of how they can do it, how we can maintain focus on essential services, not get distracted about ventilators when we're not even getting the basics right in many settings, and addressing existing inequities, particularly in rural and poor regions. So I just want to finish off by giving you a few sort of things to look out for in the next 6 to 12 months. The Lancet Commission will be putting out a number of things that we hope will be really well taken up. One is global estimates on oxygen need and the current oxygen coverage gap. We've heard already today that you can't really motivate the people to fill this gap if you're not articulating that was. I've given you a bit of a taste of that today. We're articulating some wicked challenges and particular solutions. There are a lot of challenges, but there's also a lot of solutions that are already in use. We're going to share some best practice examples and case studies, lots and lots of best practice examples, and also warnings that came from COVID, but also well before COVID. There'll be cost analysis and dollars to fill the coverage gap, and we're going to launch new indicators and a policy scorecard. And I think one of the really exciting bits here is one of the successes over the last couple of years is the World Health Assembly approved a resolution on medical oxygen, and this policy scorecard is going to give the global community and national governments something really tangible to be able to track that and report against that, and indicators to actually work out whether what they're doing is having an impact on lives like the life of that girl that you saw. So thank you. I'm very happy to take some questions. No questions. I think the next regional health assembly is in New Delhi next year, and we'll certainly be bringing some of the big landmark results there and getting a lot of involvement from governments and civil society around that.
perhaps just one question then. Sorry, I'm not going to let you get off that easily. But you talked about wicked challenges and their solutions. Is there one that you would highlight as, you know, a particularly creative solution, or are we just dealing with things that we already know, that we know what we should be doing, how to do it, we just need to get it done?
There's lots of amazing solutions. Maybe just to pick a couple. One of the big challenges has been getting supply, not just production, but supply out to the distant facilities. There's some great innovations in our region, in island states, of using solar power and basic oxygen concentrator technology to be able to provide small clinics and small health facilities with oxygen. I think on a bigger scale in India, there was oxygen supply and particularly distribution became really highlighted during COVID, and that stimulated the development of a national oxygen grid, where they're able to map where oxygen is being supplied and critically where it's being distributed. Because in India it wasn't so much there wasn't enough oxygen being produced, it was all locked up in one part of the country in industry and had to be actively diverted to medical use and distributed to other parts of the country. So maybe that's just a couple of tasters.
From a technology standpoint, is there any innovation or breakthrough that could make it easier to deliver oxygen to people without power or the complicated instrumentation?
Really great question. So for a lot of small facilities, we've been dependent on oxygen cylinders, which are big, bulky, and really expensive and difficult to transport, or oxygen concentrators, which have the advantage of being able to use locally, but they require power. A few years ago, UNICEF put out a target product profile of a better concentrator, because these concentrators are built to be used in North America, in Australia, for patients on long-term home oxygen, not in hot, humid, dusty environments. So there are a few new concentrators that have come out that have much better specs around heat, humidity, durability, and more efficient power supply. So that's encouraging, but I think there's still lots of space for more improvement.
I was wondering, I'm a climate justice lawyer, so I was wondering what your implications your research has for the relationship around, is there an increasing oxygen need and, you know, carbon emissions, not only from a preventative perspective, but for future requirements?
Yeah, really good question. So with oxygen, I've mostly talked about what you do when someone needs oxygen, but there's a whole other question of how do you prevent them needing oxygen in the first place, and particularly things like PCV, immunisation, other preventive health measures have been really important. What we've seen mapped out is there is still an increasing need in terms of numbers of people needing oxygen for acute conditions. How much that's, it's obviously impacted by a lot of things. So we see changes in disease epidemiology, which is also linked to climate. But I expect we'll still see an increase. I guess the other big linkage for our work is just about energy, because a lot of the oxygen production, whether it's bedside concentrator or a hospital-based oxygen plant, are highly energy intensive, and that both has huge immediate cost implications, but obviously depending on your energy source, potential carbon emission as well.
Cool. Thanks, Hamish. I had a question around oxygen purity. So obviously delivering oxygen is really important, and what we've found is there's definitely a vast difference in the quality of oxygen being delivered. So, for example, one site we visited last year was actually running about 38% purity levels from the oxygen plant, and the clinicians had no idea. What's sort of some of the approach that you guys are taking with sort of addressing that?
Lots of, because said on that, I'll try and keep it short. We've found very similar things when we're testing concentrators. They'll be using them clinically, but it'll be blowing out air. What we breathe is 21% oxygen. What you need in the vast majority of cases, if you need supplements, is just a little bit more oxygen. You're never wanting to breathe in 100% oxygen. So even if you're using oxygen that's 100% purity, you're breathing in with all the ambient air around. In general, there's different standards for medical oxygen, but in general, you're wanting your machines to be producing at least 90% oxygen. And regardless of whether it's 85% or 95% or 99%, it doesn't matter for the patient. But the big concern is when you think you're providing sort of 85, 90% and you're actually just blowing out air. That's a real concern. And a lot of the recommendations and the work that's been done is how to support biomedical capacity so that we're able to maintain this equipment, check this equipment, and make sure we're actually providing what we think we're providing.
So I'll introduce our final presentation for the session. So we have Professor Kim Cornish, Professor and Director of the Turner Institute for Brain and Mental Health at Monash University, to speak about the global post-pandemic child mental health crisis. Thanks, Kim.
Thank you. In 2021, UNICEF's report, The State of the World's Children, argues that the pandemic may represent the tip of the mental health iceberg, an iceberg we have ignored for far too long. Now, skipping forward to 2024, and children's mental health across the globe is in absolute crisis. The cumulative effects of climate change, of war trauma, and a global pandemic have left over 1 billion children worldwide vulnerable to the impact of poor mental health and well-being. And all too often, research and policies have almost started in adolescence and then moved into adulthood. They have rarely begun in children, in childhood. Even as children enter school for the first time, we know enough, but we know enough to know we need to develop programs that are impactful, but we don't know the exact the exact trajectory of children who have mental health problems and challenges as young as 5 years of age, and what that impact means in the teenage years and into adulthood. We also know that the greatest devastations are in our vulnerable communities, in families living in poverty, in living with fear and trauma, living in cultural disadvantage, and living with disabilities, to name just a few. The impact is global, and action is needed right now. We know enough research to know the devastating, insidious trajectory that poor mental health in young people and young children, what that means for their adulthood and their teenage years. We know that children who have poor mental health in the early years and it remains untreated are likely to follow a lifetime course of poor educational outcomes, of addiction, of later psychiatric disorders that will need medication that is throughout their lives. We know that the employment and stability in the workforce changes when children do not have when children do not have interventions that will really impact their lives. So we know what our research tells us. But what we don't know is how we actually put this into our society. How do we impact all the children that we know around the world? How do we break down silos so that big tech, researchers across many different disciplines, different types of digital systems and technology can be built? How do we work with families and communities? How do we tackle cultural diversity? How do we move away from a one-size-fits-all model of intervention? And how do we work together to develop appropriate resources, bringing in global expertise, working with countries together? We know that early intervention is the key. But how do we transport that early intervention into cities and cultures that are so diverse. I would like to argue, and although it is in very young days at the moment, the potential power of responsible AI to deliver services, to deliver accessibility to resources that can be developed and personalised to communities, to look at how we can use the technology around us, how we can use the people around us, to me, is one of the keys to unlocking and really beginning the journey of healing our children's mental health, no matter where they live. In January this year, Aaron Greenberg from the UNICEF Senior Regional Advisor for Europe and Central Asia stated that mental health and psychosocial support services have long been under-prioritised and underfunded in humanitarian services. I would suggest that now is the time to tackle working in the communities, working with families. At the heart of most communities are the schools, looking at how we can develop interventions through AI, through other technologies that can actually be administered by schools into families wherever they live. In our own country here in Australia, we have the highest rate of school refusal in children we have ever seen in generations. We have children not going to school. We have children with elevated anxiety levels, elevated stress and fear. Friendships never formed. Formative years of those early schools from 4 to 6 years, children instead not being in the classroom, schooling from home has caused, a huge impact on our services. If you live in metropolitan Melbourne and you can pay for your services, then you may wait only 6 months to see a child psychologist. If you cannot pay and you're depending on the public service in metropolitan Melbourne, you may wait 12 months. If you are in rural and regional Australia, you will be waiting up to 2 years to see a child psychologist. And this is in Australia. Those 2 years, if you do not have intervention, will deliver a lifetime of disadvantage to these children. So I would like to really embrace the fact that AI and technologies around it can offer a solution. There are issues, of course, with HI, biasing and so forth. It's brand new for many, but it has a positive potential, sustainable impact that might be able to deliver services, deliver resources to parts of different countries we would never think possible. So I'm going to leave it there, but the time is now to act. Thank you.
Questions already?
Thank you very much. Thank you so much, Professor Kim Cornish. I absolutely agree to you that children need interventions. At the same time, as I'm from Bangladesh, definitely I'm thinking about my context. We have, I think, 296 psychiatrists for 180 billion population.
Wow.
Yes, and we have around 300 psychologists for this amount of population. So hardly one psychologist per million population. Yes. So when we are saying we need interventions for children, what sort of interventions we are thinking where I can arguably say, like, it's not possible for allocating or kind of, sending psychologists to all schools. It's not possible.
No, I absolutely get that. Absolutely get that. And I've done some work in Malaysia, and we were in the same position there. So what we did was that we worked, I think working with communities is vital, looking at how you can translate the gaps into technology, that even when a child presents with just a few symptoms, for example, really worrisome behaviour, anxiety, poor focus, distraction, and so on, that can then be triggered to look at early interventions that can be delivered to you at home, that can be delivered at school. There is a whole research base out there. What's not there yet, and I find this when I worked in our Malaysia cohort, is that there is a tendency to just, when you look at what teachers and what families can do and health professionals can do, is simply to take something that was built in the UK or built in America, standardised on children in those countries, and deliver them in a country like Malaysia, where it has no impact whatsoever. So the first step I would love to do in so many countries is to look at how we can work with those communities to actually develop programs that are based on their children and what parents can do, what teachers can do before the need for a clinical assessment.
Okay.
Thank you.
Thank you.
Thank you for the great presentation. I'm Rong Bin from Monash University. My question is so I'm interested in how the AI technology could be used to improve the development of the interventions, because AI has some problems such as they can make mistakes and they can
I think the key is to walk before we run with AI. You can see what the future of AI could be in time to come. For me, if I was developing a program that was trying to get into all the schools in rural Victoria, for example, I would be looking at a system whereby we know, teachers know, parents know, and have information what signs and what behaviours to worry about. When they see that in a child, they can tap that in, and then that will come out with a series of early interventions that they can try with their children. Looking at how we take that, the next step from there would require data that we don't yet have, but we will have. So AI, used responsibly and used in a way that is there to promote mental health and not in any other way that is too far advanced and could cause damage, is what I would be looking for to do. And yeah, hopefully that's around the corner. I know that at Stanford University in the US and also Toronto in Canada are steps going forward in how we can move that into the classroom responsibly. Thanks.
Another question at the back, but just in the meantime, I might ask a question, Kim, if that's okay. Yeah. You talked about the pandemic and lockdown, but we also have other, environmental events like floods, etc. Are you also considering how some of those, I guess, more acute impacts might impact mental health and access as well?
Yeah, that's a really interesting question, because in many ways those happen in regional and remote Australia, looking back over the last couple of years. And no, I don't think there's, for those that had the double whammy in 2019 of the heat and then pandemic, there's been virtually nothing to alleviate the trauma of those children. So we're really behind, and we need to cut down the silos, and we need to work together in our communities.
Hi, I'm a doctor from a regional hospital in Victoria. Sorry. And since the pandemic, we've seen a huge increase in mental health patients in the hospital itself, especially younger patients. I just thought if you have any insights on what's the cause of this, and also if you mentioned a few programs, if you have any programs that's suitable to help us or that you have in mind, you can update us on.
Yes. Did you say the cost? The cost.
The reasons for this, explode in mental health patients, especially.
The reasons for the increase?
Yeah.
Oh, yeah, sorry.
If you can give us a few insights, thank you.
For me, the reasons for the increase will relate to the absolute, I can speak in for Australia, the absolute fear that children went through in the first 2 years of the pandemic. We had just simple things that now on reflection you think, for our children, how could it have had the impact that it did? But in Victoria, for example, on every playground area, we saw the yellow and the red tape. We saw it wrapped around, and for every child that spells danger. So even walking into a park, you felt that the space that was yours was now no longer yours. You have the fear of the internet, of all of the images, everything that was happening around the world was available to the eyes of young children. You have them going into fear. When I look back at how I expected children to be going back into the classroom after the pandemic, I thought they would be running back. There's just trickled back, and they're still trickling back. So the fear, the uncertainty are so deep in children. And that's in Australia. You know, we look at countries like Bangladesh and others, many others, where the impact is even worse. So in terms of programs, looking at, and again, just looking from an Australia perspective, but for example, positive parenting, which is an online app that can be delivered to parents and in some ways to parents to really help their children, developed by Professor Marie Yap at Monash University, is one way that evidence base has got through into practice and through into the hands of parents. But one of the key drivers for a change is the fact that we have a handful of programs on children's mental health for children, but depending on what state you live, you won't have access to them. And some you have to pay for. We have mental health resources for teachers in a very loose-fitting way. So they're never really taught in children's mental health. They may have access, they may not. And likewise for parents as well. There's some access, there's not. So it's all in silos. We need to bring it together, and we need to then be able to deliver it, in my vision, within schools, out to all children everywhere. Thanks.
Very quick question.
Can I just add a comment to that? I think to make it even better, you would be looking at the mental health of parents and teachers as well.
Absolutely, yes.
Because otherwise what you will have
Yeah.
is a continuation of siloed and unconnected outcomes.
That is brilliant, and I should have said that. Of course, we need to do, because if your child's mental health is so poor, the fact probably your parents are as well.
And baby.
So looking at it all holistically,
100%
together. Thank you. Yes, thanks for raising that point. Thank you.
So just maybe just to continue the applause, to thank all of our speakers today. It's been a really diverse showcase of different activities, which are from a call to action to generating the evidence base to inform policy decisions around evidence, you know, around investment in population screening. So, and how we get some practical solutions into the hands of those who need it in the case of Ollie. So really great session. Thanks to Sally for putting it together. And I hope you all have a wonderful lunch. I encourage you to walk down the stairs and then walk back up later today.